gentlemen, good morning. The topic that has been given to me is basics of mechanical thrombectomy. Let me start off with what is the basic kit for mechanical thrombectomy. So, whenever we talk about basics of mechanical thrombectomy, the easiest thing to remember would be it is better to have a kit bag in your cath lab. Why am I saying that? MT is a very high tension zone. You know, everybody is running around to do so many things and so many works. Somebody is looking at the patient, somebody is looking at what materials are available, somebody is taking a consent, somebody is calling the anaesthetist, somebody is praying to God. So when all this is happening, it is better to have some part of your structures organized. One of the things that could be organized would be a kit bag to have, which will have the essential equipments that you need for a mechanical thrombectomy. So basically it's a kit, it's like a go-to bag. It is a pre-prepared kit that eliminates the need for us to worry about gathering material. So when I look at this kit bag, and why am I talking about this kit? I'm structuring this talk based on this kit so that you will be able to understand what are the steps of mechanical thrombectomy. So this is how it should be. It should be very organized. The cath lab should be very calm. It knows where it is. You see, So you see a cupboard over here where things are all lined up. Here are things that, you know, like an OT tray where everything is ready, and then there is a nursing assistant who's preparing the table. This is how organized it should be. And you should just go and pick whatever stuff you want and then come out and start doing the case. It should not be like, okay, I need this material now, and somebody runs to the store to get it and now. Anyways, before I go into MT, what are the prerequisites for doing a mechanical thrombectomy? The first and most important thing is you need a non-invasive angiogram, preferably a CT angiogram or an MR angiogram before you do an MT. Now, this is a prerequisite because that is what guidelines say. Today, the world is moving to a one-stop angio suite where the patient with an acute stroke, instead of going to the CT room, he goes to the cath lab and the cath lab is already fixed with the CT. You wheel the patient inside the cath lab, you do a CT, it's a bleed, you go straight into the stroke unit. If it's not a bleed, you want to check if it is a large vessel occlusion, you do a CT angio then and there. And if required, you thrombolize the patient there. So imagine ER, stroke patient, goes straight into the cath lab, from the stroke cath lab to the stroke unit, which Dr. Bimanda was talking about. That's where the world is moving to, one-stop angio suite. But till we catch up with that, at least one CT angio is required to demonstrate large vessel occlusions in acute stroke. And how is the CT angio? It should cover from the arch and the neck vessels all the way to the brain. So whenever we talk about a CT angio for a patient who has a stroke, we only look at the brain, but it's very important to know the neck and the arch as well. It is like if you want to go to Tirupati, you should also understand the route in which you are going to take it. It's not just it is there in the southern and the eastern part of India. It doesn't work like that. You have to understand through which states are you going to go, through which cities are you going to go, so that you reach your destination. Kidnap an anaesthetist. Like Bimanda was talking to us about, always have an anaesthetist by your side when you are doing a procedure in the cath lab like mechanical thrombectomy. The reason is because these are patients who will not listen or will not be in a state to listen to your commands always. How many of you have shifted patients in acute stroke to the CT distress or vomits, then you will suddenly be in a panic state? So better to always have an anaesthetist with you when you are doing a mechanical thrombectomy. If not at the start, at least see to it that they reach the place as you are proceeding with the procedure. Know the drug histories, especially whether the patient has been thrombolized or not, patient has been given anticoagulation or not, because the amount of heparin that you are going to give in the procedure and the kind of pricks that you are going to do the procedure matters a lot. A high-risk patient with patient who is having anticoagulants or thrombolytic therapies and all that, it would be good to look for ultrasound-guided punctures. You should be very clear that you are puncturing on the femoral head, not somewhere else. You all know this. If the patient is on a good load of anticoagulants and then you puncture at places where you cannot compress, then you will end up, before even the procedure, losing the patient. Keep an ultrasound accessible. Ideally, every cath lab that you order or when you are working in, you should ask for an ultrasound. If not, at least see to it that the ultrasound comes to you when the procedure is being done. Next comes the route. So this is how it is. Now, from the you reach the top from the base camp, and you have different points like a pitch top. So like the same way, This is how we go. You start from the femoral artery, go to the arch, then to the carotid, and then to the MCA, ACA, whatever blood vessels you want. So you start at the femoral artery, arch, carotids, and then the distal vessels. Some of them have started doing radial access now. I am not an expert in that, so I'll stick only on femoral, arch, carotids, and brain. So this is us coming from the femoral artery, and this is our price. We have to go all the way into the intracranial circulation. And there are basically only two ways to reach there. One, you climb on something, or two, you take a rope and try to pull yourself out. This is called tower of power. So you climb on things, and then you reach, or this is called wire purchase, where you put the wire up and use that wire to climb. Sometimes you might use a combination of these two to reach here. So the only way you are going to reach your price is tower of power or by wire purchase. Simple. Okay. So now coming to the femoral artery. This is very confusing for me as well. We usually use an 8 French sheet, and many of our catheters and wires are given numbers in millimeters or inches. I don't know why this combination has happened, but generally what we remember is if there is an 8 French sheet is required for most of the neurovascular procedures. If you're doing a neurovascular procedure, I'm not talking about diagnostic angiogram, any neurovascular procedure, minimum a 6F or an 8F is required for you to do the procedure. If you're able to take this home, that is enough. How much is it in terms of millimeter, how much it is in terms of inches, you can just remember this. Sometimes we use a 5 French sheet to dilate the blood vessel, and then we take an 8 French sheet. It's always useful to keep a radial kit handy, because most of the time when you get a stroke patient, these are patients with diffuse atherosclerotic disease. You may not get a femoral pulse, and at that time you will panic. You could have a radial access, and then you could go with the 6 French sheet of the radial as well. So just keep this in mind. Then comes the guiding catheter. So basically what type of arch are you dealing with decides on what type of catheter you are. So this is a type 1 arch, this is a type 2. Almost like taking a U and then a second U. It's like an S-shaped bend. Are you able to understand this? Remember that this is at the arch level, and we are operating at the femoral level. So when you are taking the catheter up, it is very difficult to do these maneuvers. You cannot make your catheter just take a zip. Imagine a Foley is going through a curved space. When it is going like this, it's just straight. So the arch which you cover in your CT angio is going to decide what type of diagnostic catheter or guide catheter you have to take in order to negotiate this term. So this is one example where you can actually see how they have managed to negate or managed to navigate into some difficult arches. There are different techniques, I'm not going in, but what I'm trying to tell you here is based on the structure of these arches, you could decide what type of catheters are there. So whenever we do a diagnostic angiogram or a therapeutic procedure, there are catheters that come with different shapes which has different purposes. And once you are exposed to these catheters, at least 2-3 of them, for example, SIM is a good catheter to navigate through this. Then you have a VERT, then you have an H1. So when you cover the arch, you can actually decide what type of catheter you need so as to cross the first summit point, first base camp point, so as to reach the carotid artery. So next is a wire. So as I told you before, after the tower of power, the other most important thing is wire purchase. The common wires that we use is called a thermo wire. We also have a stiffer wire, and then we have something called an exchange length wire. What is an exchange length wire? I'll show you here. So imagine this is your arch, and then you take your diagnostic catheter into the common carotid, and then I place my wire here like an anchor. Can you see it? It has hooked itself on the vessel. Then what I do is, this blue diagnostic catheter, I start taking it out, but my wire still remains. And over this wire, I am taking a larger system inside, something fatter, so that it can accommodate more vessels. This is called exchange maneuver. So you have a small catheter that helps you access the carotid, then you keep the wire in, then over this wire you remove this diagnostic catheter out, and then you take in a larger sheath or a larger catheter system inside, so as to help you do the mechanical thrombectomy. This Seribase DA is one such catheter that we take up all the way to the carotid so that we are able to do a mechanical thrombectomy. So I was telling you about tower of power. So usually we use neuron max, Seribase, ballast or scoop sheath. In this diagram, this is your support catheter or this is your guiding catheter. Now imagine he is actually supporting two more people on top, which means he should be like this and he should not be like this. Correct? So this system should be ultra strong, and that is why we use something that is very solid so that it is able to support any system that goes up. Okay? Balloon guide catheters. They are otherwise called flow arrest catheters. The idea of balloon guide catheters is that you put this balloon guide catheter inside the internal carotid artery. Why the internal carotid artery most of the time? Remember, internal carotid artery, through most of its course, up to probably the ophthalmic segment, doesn't have major arteries that are moving out. So the moment you inflate the internal carotid artery, that means for all practical purposes, you have arrested the flow. Of course, there are embryonic connections that are there. I'm not going into detail, but at least from a mechanical thrombectomy point of view, if you were to inflate the balloon inside the internal carotid artery, then it is caused flow arrest, which means if there is a clot that is here, it will not move forward. But it's not enough that you just put flow arrest. You will also have to do something called flow reversal, which means you'll have to start aspirating from this catheter so that if there is a clot here, that starts coming out from this one. So balloon guide catheters are important part of your toolkit for mechanical thrombectomy because it achieves flow arrest inside the carotid artery system, thereby preventing this embolus to move. So this is the wire purchase that I was talking to you about, and this is the Seribase that is going. You see all the way from the arch, it is going all the way into the internal carotid artery. The mandible is a good landmark to have, especially when you don't know or when you're just doing it under fluoro. If it crosses the mandible or just around there, that is where the bifurcation is. Then once you have reached in, you have put your balloon. There are two basic methods of doing mechanical thrombectomy. One is an aspiration and the other is a stent retriever. Of course, there are various combinations, various techniques, badass, adapt and all that. I'm not going into those details. I'm just going to give you some basic idea of what is aspiration and what is stent retriever thrombectomy. So this is a basilar top occlusion, basilar artery occlusion. It's actually the top, and you can see our aspiration catheter removing this clot and coming out. And this is our guide catheter or the guiding sheath. It is as simple as it is. You just need to take one sheath inside the vertebral artery. You need to take your aspiration catheter all the way to the basilar, remove the clot and come. Trust me, the learning curve for this part of neurointervention is not so much as to do other hemorrhagic or other complicated work. That is why I feel that as neurologists or neurosurgeons or clinicians who are practicing stroke medicine, mechanical thrombectomy should be basic training for everybody. Because this does not have as much as a learning curve as other neurointerventional procedures. So this is simple aspiration. So this is a stent retriever, I guess. Yeah. So this is a left M1 occlusion. So same way we have a sheath over here, and this is the stent retriever. We have deployed it with a microcatheter. You can see the stent retriever. I hope you are able to see it. Are you able to see the stent strut here? Yes. You can see those markers here, here, here. Can you see them now? And then we do a mechanical thrombectomy where we remove this stent retriever with a clot out. Were you all able to see this? Yes? No? Do you want me to play it again or you bored? Yeah. I will just show you once more if you could see it. Just carefully see here. These are the stent struts. Can you see these markers here? Markers here? Again, same thing. So you have a catheter, guide catheter here. Then the stent retriever is put across the clot. It's called a stent retriever because it looks like a stent and it retrieves the clot. and then the vessel becomes open. Simple. So always have a RHV, rotating hemostatic valve. If you've been in the cath lab, you will understand what this is. Think about medications that you need in your kit. Antiplatelets. Suddenly, sometimes our population is more prone to have intracranial atherosclerotic disease, which means after you remove, for example, this basilar artery stroke, the moment the vessel opens, look at the configuration of the vessel after it opens. I'll show it to you. See this? Very ugly looking vessels. Sometimes they close up also after we do a mechanical thrombectomy. So you might want to give some other kind of antiplatelets over there. Ticagrelol, tirofiban. So know your antiplatelets, whatever is your favorite, and see whether that's there in your kit. Of course, have backup materials for complications like snare, stent, balloon, liquid embolic agents or glue. How many kits we should usually have? Depends on you. I usually have only one kit. I'm a very big fan of aspiration to mechanical thrombectomy. It's a simpler procedure. You can decide with aspiration or stent retriever or that. You could decide based on whether you're dealing with a hard clot or a soft clot. This is where the direction of understanding stroke medicine is going. Hard clots are usually in CT and plain CT, you don't see those hypertense signs. They are fibrin-rich clots and they are not very easily amenable to mechanical thrombectomy. And if you see those, maybe you can go in with multiple devices in the first type itself. Maybe you can use an aspiration with a stent retriever. You see a soft clot with a hypertense sign, maybe one of the techniques, either stent retriever or aspiration would do. Proximal versus distal lesion and tortuosity of the vessel. Keratids are very bad, arch is very bad, then try to look more for stent retrievers. Straightforward, young patient coming into the stroke, aspiration thrombectomy would be very good. So you have to decide your kit based on how you assess this patient before it enters the cath lab. I think that's about it. This is my current team here, this is my fellow, and this is my neuroradiologist. Dr. Bimanda was talking about a team. It is very, very important to have a stroke team. At least you have to understand that you cannot be on a 24/7 call. At least you need one more person who is ready to take that burden. So this is my gentleman here, and of course this is my fellow. I'll be happy to answer any questions that are there. Thank you so much.